Hi everyone, let's talk a little bit about Section 5, respiratory problems. We know with respiratory problems that we have certain common complaints, first being cough, which we know is a natural protective response for clearing airways. It can be caused by pulmonary secretions, increased sensitivity to the receptors in the airway, stimulation of the cough reflex, certain diseases such as cancer or tuberculosis, cardiac issues, occupational exposures, chemicals, smoke, things like that. It can also be the result of medications such as ACE inhibitors. Other common cough complaints include dyspnea, which we know is shortness of air, and it's a common complaint in healthcare. It's a perceived sensation. It's described as the sense of difficulty breathing or not feeling like you're able to get enough air in. And then the last common complaint we will be talking about is hemoptysis, which is coughing up blood. So when we think about these common complaints related to cough, we have to work up our differential diagnoses, and there's several questions that should be included with that. And what are some of the factors that prompt the cough? Does the cough happen when you're laying down, when you get up, when you exercise? Does something make it worse, such as exercise or cold air? What helps it? A change in position, avoiding exposure to certain allergens, such as smoke or grass, things like that. The type of cough, is it a dry cough? Is it a wet cough? Productive or non-productive? Ask them to describe the color and the consistency and the amount. And then if there's any associated symptoms with it, such as dizziness, chest pain, pedal edema. Conducting a good physical exam to include your head, ears, eyes, nose, and throat is important. You need to palpate the neck for thyroid and lymph nodes. You need to do a good exam of the thorax and the chest. And ask the patient to reproduce the cough so that you can hear what they're describing. Most times the cough can be determined by the history and physical, but other tests that you may include might be PPD, a chest x-ray, spirometry, CT, and maybe a CBC. After you've decided what has caused the cough or what you feel you're comfortable with diagnosing the cough with, there's a couple of options for treatment. One is dextromethorphan, which will help suppress the cough. Then there's Bromfed. There's also the benzoate, which are your Tessalon pearls. You can use codeine for short term to help suppress the cough, which may be used also more at nighttime. Phenergan elixir is also used to help suppress a cough. You can use decongestants, antihistamines, intranasal steroid sprays, and expectorants like guaifenesin. And when you're prescribing those, it's important to educate the patient on they need to have increased water intake. If you have a patient who's had a cough related to GERD and it's triggered by reflux, it's going to take them several weeks before that cough will improve. So just advise them of that. All right. Our next one that we're going to talk about is dyspnea. And as we talked about, that's a shortness of air that occurs primarily associated with the respiratory and cardiac disorders. It could be caused by a neoplasm, neuromuscular issues, spinal cord lesions, or panic disorders. In terminal patients, it's a common secondary symptom to pain. When we're considering our differential diagnoses, in the pulmonary department, it could be COPD, asthma, interstitial lung disease, pulmonary hypertension, mechanical factors such as obesity, ascites, or pleural effusions. In the cardiac spectrum, it could be congestive heart failure, mitral stenosis, or regurgitation. Hematologically, it could be anemia, and it also could be anxiety or panic disorders. I'm going to put us on hold for a moment while I shut down my email. Dyspnea can be considered acute or chronic as well, and about 75% of the cases of dyspnea are are respiratory related, and the rest make up cardiac related dyspnea. And important questions that you should ask to further assess the shortness of air is: how many flights of stairs are you able to climb before shortness of air? How many blocks may you be able to walk? How many feet can you walk? Also ask about their speech when they're walking, because that's a good indication of shortness of air. When you're going to do a physical exam, be sure and include the respiratory and cardiac systems. So you want to check vital signs, you want to check breath sounds, you want to know, are there any third or fourth heart sounds. If you feel diagnostics are in order, you may order a chest x-ray to rule out tumors, tuberculosis, or pneumonia. You may do a CBC to rule out anemia or infection. You may do a complete metabolic profile. If your pulse ox is less than 90%, you may consider ABGs. And if there's been carbon dioxide exposure, you may decide to do a carbohemoglobin. Management is related to the cause, and based on what those causes are, will be discussed in specific chapters. The next thing we're going to talk about is hemoptysis, and the main goal with hemoptysis, we know that is coughing up blood, whether that is pink tinged sputum or someone copiously coughing up blood. But the main management technique is maintaining the airway. And if it is a chronic hemoptysis, then we need to figure out what the underlying cause is. Common causes for ages less than 45 include mitral stenosis, tuberculosis, bronchiectasis, or a lung abscess. Greater than 45 could be a cancer, bronchitis, tuberculosis, or a pulmonary emboli with an infarction. Sleep apnea, we're not going to go into great detail with this. You need to be aware of what sleep apnea is and some common assessment tools, but likely if you're concerned with someone with sleep apnea, then you're going to be referring them on to pulmonary. But sleep apnea is when there is a sleep medicine specialty. Sleep apnea is when there's pause in breathing from anywhere from 10 to 90 seconds. You can have central apneas where there's the absent airflow and loss of respiratory rate, and this can be seen with neurological diseases, or obstructive apneas, which are related to the tongue and soft palate, and this is when those parts of the oral pharynx fall backwards. Then you can also have mixed apneas. A couple of diagnostic tests that you can have your patients complete is the Stanford Sleepiness Score and the Epworth Sleepiness Score. There are some home sleep apnea test that you can order through DME companies, but the definitive test of sleep apnea is an overnight test where they're all hooked up and they're being able to be assessed for movement and when they stop breathing, and this will be evaluated by sleep medicine or a pulmonologist. And then also, when you might be having these patients, it's important to be sure and look at the size of their neck, measure their neck, and look on the inside to see how spacious their palates are. Medical management, avoiding alcohol, sedatives, or hypnotics. Losing weight is often beneficial. These may be patients that you might have to have on oxygen using nasal strips. Those are some key factors that you can start in the primary setting. Another option in the primary setting is referring to dentistry. They can often make devices that will keep the tongue from sliding backwards, which often may be beneficial for sleep apnea. Next, let's talk about some common respiratory problems. These can include bacterial infections, influenza, the common cold, acute laryngitis, epiglottitis, and RSV. And adults can have RSV, and it can cause severe pneumonias and lower respiratory tract infections in older or compromised adults. The flu, the common cold, and acute laryngitis are your most common upper respiratory infections. Most are viral, with the most common cause being the rhinovirus. the older coronavirus, not our current coronavirus, and adenoviruses. Upper respiratory infections caused by bacteria have similar organisms to the ones that cause otitis media, such as strep pneumoniae, H. flu, Staph aureus, and then the Moraxella catarrhalis. Some of the signs and symptoms may be an abrupt fever, chills, fatigue, muscle aches, headaches, nasal stuffiness, sore throat. During certain times of the year, diagnoses may be presumptive based on the time of the year and the caseload that you're seeing, but if you're wanting to do testing to confirm, you can do virology tests, and that may include nasal swabs and throat swabs. Continuing with upper respiratory, the treatments for cold and flu is generally symptom related as they are viral. They have to run their course, but there are antiviral medications out there, such as Tamiflu, that you might consider. Antibiotics, as we know, are not needed for viral infections unless there's a secondary infection noted. If you do feel that someone has type A flu, treating with an influenza antiviral such as Tamiflu is standard treatment and recommended to start within 48 hours of symptoms. You need to encourage fluids, rest, and any medications to help keep their temperature down. For acute laryngitis, voice rest, fluids, steam, cough medications. If you do a throat culture and it is positive for strep, then first line treatment is with penicillin. With the flu, you can have a common complication of pneumonia. I think we talked about a good bit of this, but common complications also include, besides pneumonia, acute sinusitis, ear infections, bronchitis. If fever is greater than 4 days after, if it increases after 4 days after diagnosis, if their white blood cells are greater than 12,000, if they have a productive cough, then you need to evaluate them for a bacterial infection. In regards to these pneumonias, pneumococcal pneumonia is the most common, but they can have a staphylococcal pneumonia. And then you can have viral pneumonias, but there's a higher mortality if this type of pneumonia among pregnant women and patients with rheumatic heart diseases. So this leads us right into community-acquired pneumonias, or CAPs. The leading organisms are strep pneumoniae, Moraxella catarrhalis, H. flu, Legionella, and Staph aureus. We talked about viral pneumonias. The mycoplasma pneumonia is considered a walking pneumonia. And then our other organisms there. With the typical pneumonia, be sure and look at box 30.3, but some of the symptoms for onset include sudden fever, productive cough, rust-colored sputum or purulent sputum, pleuritic type pain, splinting, chills, myalgia. Objectively, you may have someone that has crackles, dullness on percussion, pleural friction rub, decreased or absent breath sounds. Then you may note shadows on one or more of the lobes in the x-ray. With pneumonias, often greater than 50% of the time, they're unable to determine the organism that causes the issues. But as we talked about previously, if your WBC is greater than 12,000, it's considered a bacterial infection. Let's see what here maybe we not have discussed. Treatment is the most important, is to determine whether it's something that can be determined outpatient versus inpatient. An assessment tool that you can use for that is the CURB 65, and it is a tool that determines the severity of community-acquired pneumonia. Antibiotic choices are listed in the book, and if you are treating as an outpatient, it's important to educate to call for symptom worsening and to follow up in 1 week and 4 to 6 weeks after initial evaluation to assess how they're doing. Here are the antibiotics of choice for community-acquired pneumonia. And first line without recent antibiotic therapy would be a doxycycline or an erythromycin, and recent therapy is considered within the last 3 months, but you can review that as a reference. We'll go over quickly tuberculosis caused by the Mycobacterium tuberculosis. Hemoptysis is a frequent sign of clinical infection. You can have symptoms to include anorexia, fatigue, weight loss, cough, yellow secretions. On x-ray, they can be seen Ghosn complexes. There are screening guidelines that are found in the book on page 381, and I don't know if we have any of those. I don't think we do. I think we all know how to do a TB skin test, and we're not going to go over that, but the most important thing is to produce a wheal when you're doing an injection and make sure that it is read in a timely manner. If you have a TB skin test that is positive but chest x-ray is negative, the guidelines recommend treatment, and in the book there are at least two, I believe, I don't have the book here with me, two charts that talk about medications that would be used. If you have clinical suspicion that someone has TB, then you do a chest x-ray and you examine the sputum. And the sputum should be collected for AFB and done on 3 separate occasions, 3 different days. Let's see. AFB, as we talked about, or acid-fast bacilli, is what you will see in the sputum smears, and it's often detected in 50 to 80% of pulmonary TB. If that comes back, then culture should be sent out, and these usually take about 3 to 6 weeks to completely grow out. In the management, medications are recommended for all positive TB skin tests. On box 9.2 talks about first line and second line drugs, and it's important that they are treated for at least a minimum of 6 months. If someone has HIV, then for 9 months. And then it's important to discuss with them direct observed therapy. These are folks that will likely be followed by the health department, and you will help manage them in conjunction with them. In TB monitoring, certain medications can cause visual acuity and a red-green color perception issue. It can raise your serum uric acid. It's important to assess these patients for lack of appetite, nausea, vomiting, fatigue, change in urine, itchy skin, numbness, tingling to the hands or feet. It's important to check weight, temperature, changes in any type of symptoms. And then after treatment is done, it is important to make sure that you have negative skin test and negative sputum test. Take that back. You're not retesting for skin, but that they produce a negative sputum at the end of treatment. These are, as I said, are patients that are likely overseen with the help of the health department, and I would recommend that you could send them for evaluation to pulmonary as well. All right, let's talk here briefly about asthma. With asthma, there's 3 principal triggers, whether those are allergens or things in the environment, such as inhaled substances, food, or medications. Asthma can be triggered by infections, such as an upper respiratory infection, or they can be triggered by stress. When we're going to work on the diagnostics for asthma, you have to determine the type. So you are trying to get more information, knowing that there can be episodic symptoms of airflow obstruction. The obstruction, could it be reversible? You would do PFTs, and you could do those as pre-bronchodilator and post-bronchodilator to see what the differences are and compare those. ABGs may be considered as part of your initial workup. Chest x-ray may show that there's been hyperinflation, a thickening of the bronchial wall. And in the CBC, you may note elevated eosinophils. Remember that on a CBC, we have the white count, and then we have 5 subsets of the white count. And the eosinophils are the ones that tell us more about allergic responses. So here is a snippet from the book that talks about essential elements to consider when diagnosing asthma, such as cough, wheeze, shortness of air, and chest tightness. Symptoms worsen in relation to certain factors such as exposure, exercise, reflux, medications, environments within the home. Could it be smoke or bugs? Viral infections. And then also, could any of these symptoms be reversible to help with airflow limitations? Asthma severity. Review this chart. There may be a question or two on the first exam that has to do with the type of asthma, such as its classification and some of its clinical features. So be familiar with this chart. Some of the principles of management of asthma are working with your patient on what are the exacerbating factors. There are things that they can do at home for self-monitoring, such as symptom management and checking peak flow, having a plan in place on how to manage an acute attack, and we have that here in just a moment. Education is very important, along with follow-up. Spirometry should be done at least every 1 to 2 years if they're controlled, visits every 6 months if controlled, and every 2 to 6 weeks if uncontrolled. Here is a flow chart that is based on the guidelines of the National Heart, Lung, and Blood Institute's Asthma Education and Prevention Program. But this is a stepwise chart that is a good reference to start with. It gives you ideas of where to start and things to add in at different levels depending on the step that they might be. It also discusses the different types of medications that can be used at each of those different steps. So review that. Here is a self-management plan should your patient have an acute attack at home, and different ways that the two of you have worked out how to manage this at home. So it's their home plan. Review the medications on page 403 and 404. We won't go into detail on those. What reasonable expectations can be seen for patients with asthma is in table 31.2. And then there are some risk factors for a fatal asthmatic attack, and that's on page 406. Let's talk next about COPD, and we know that that's chronic obstructive pulmonary disease, and there are 2 different types: obstructive, which is impaired expiratory flow rate, which can be reversible, such as asthma, or irreversible, including chronic bronchitis and emphysema, and then restrictive issues, musculoskeletal issues, tumors, lung resection, or interstitial lung disease. And just a little bit of a clarification on chronic bronchitis. Per the American Thoracic Society, it's deemed a clinical disorder that's characterized by excessive mucus secretions in the bronchial tree. It's manifested by chronic or recurrent cough with or without sputum production, and it's present on most days for a minimum of 3 months of the year for at least 2 successive years. And in addition, it can be with shortness of air, the shortness of air can be with or without wheezing. Some risk factors of COPD. Established ones include age, being male, cigarette smoking, reduced lung function, occupational exposures, some possible risk, infections, allergic conditions, bronchial reactivity, alcohol intake, poor diet. Debate based on what type of COPD that it may be based on what we were talking about here versus being obstructive or restrictive, goes into the different types of, such as blue bloaters, which are chronic bronchitis and pulmonary hypertension patients. They have edema to the lower extremities. They have cyanosis. They also have polycythemia, which is elevated red blood cells. Then with your pink puffers, those are the folks that have emphysema. They have more shortness of air. They may have normal ABGs, but they have more of the barrel chest. Some objective findings. The dimensions of the AP view and the lateral view is more 1-to-1 versus 2-to-1. They may have distant breath sounds. They have expiratory end wheezes, prolonged exhalation, neck vein distension, pedal and ankle edema, clubbing, and fatigue. Diagnostic tests that you may perform include pulmonary function test. If their FEV is less than 70%, that is diagnostic for COPD. Chest X-ray, although early on in COPD, those are normal. CT, labs, sputum, EKG, and you would do ABGs if the O2 is less than 90%, or if the FEV was less than 50%. Here are some common findings in the pulmonary and physical realms for obstructive and restrictive lung disease. So be sure and review those. This is also a chart that helps give classification to COPD based on PFTs, and so I would know this. There could be a possibility that some information off of this could be on the first exam, such as what type of COPD has what type of PFT measure. So just become familiar with those. In the treatment of COPD, we have bronchodilators, whether they're beta 2s or anticholinergics. We can use corticosteroids, xanthines, antibiotics if needed, diuretics, and mucolytics and expectorants. And there's more on those medications on page 412 through 414. On education of the COPD patient, we want to recommend smoking cessation, doing yearly influenza and pneumovax, PT, support groups, ways to breathe that are getting more air exchange in, oxygen therapy. We need to assess them for depression, and if we note depression, to be able to help them manage that. And then, depending on where the timeline is of COPD, talk about possibly some advanced directives if their breathing is becoming more of an issue. Here is the iceberg of COPD and all the different facets that make that up, whether it's medications, surgical, psychosocial, self-care, teaching, environmental, mind, body, and nutrition. So you can review that, and that was taken from the book. Briefly, let's talk about lung cancers. Some of the subjective symptoms include cough, sputum, hemoptysis, shortness of air, wheezing, chest pain, and pleural effusions. Objectively, you may notice wheezing that does not disappear after coughing. Decreased breath sounds when you go to percuss on your detailed lung exam, that there is diminished resonance. There may be decreased or increased tactile fremitus. You could notice clubbing on the hands, and these patients may have cachexia, weight loss, and anemia. Diagnostically, some initial workup test that you might do to help determine the diagnosis: CBC, chemistries, coag studies, EKG, baseline PFTs, chest x-ray, CT of the chest. At some point in this diagnostic test, you're going to be referring to pulmonary likely and or oncology, and sputum cytology would come in, bronch, and then fine needle aspiration biopsies trying to get tissue to for pathology. Different types of lung cancers, they're broken down into small cell, which includes your oat cell, intermediate, and I've only seen one combined in my practice, and then non-small cell, which are more common, which include your squamous cell, your adenocarcinoma, and then there's a small percentage of large cell carcinomas. Management surgically includes a pneumonectomy or a lobectomy. Chemotherapies are in your book, but that's not going to be in your scope of practice unless you are into oncology. And but it's always good to know at least where to go find more information about chemotherapies in case you happen to see someone and they have symptoms that you're concerned about. Side effects of a particular medication, but also radiation is part of lung cancer treatment. Uh, Last, I believe we're going to talk about smoking addiction, and that is something that you will see frequently in primary care. And so, a pack-a-day smoker takes over 70,000 puffs per year. That's just a huge amount, in my opinion. Cigarette smoke also allows up exposure to 4,000 chemicals and gases to be inhaled directly into the lungs. Um, I think you all know this, but nicotine can be a have a depressive effect on the CNS. Carbon dioxide in cigarette smoking can equate to automobile exhaust. And on table 33.1, there's many diseases that are associated with cigarette smoking. When your patient presents and you are evaluating for their smoking habits, it's important to use the 5 A's to ask the questions. If you don't ask if they're smoking, then you're never going to know. Advise, assess, assist, and arrange for any supportive care, medications, etc. And there is a more detailed description of the 5 A's on figure 33.1. There are smoking cessation programs, although most of those are more online now versus face to face. Some other options include hypnosis, aversion conditioning, support groups, and pharmacological approaches. Some of those pharmacological approaches orally include bupropion and Chantix, I cannot pronounce that one. Nicotine replacement, such as patches, gums, and lozenges, and there are prescription nicotine replacement products that are nasal sprays and inhalers. Here is a list of those medications just so that you're aware. Patients often find that the over-the-counters are very expensive, and I have been asked on several occasions to see if I can prescribe them, as they think that their pharmacy or insurance may cover the cost. I'm happy to do that, but I always tell them I never know what their insurance will prescribe, but there are several options out there. And anyway, smoking cessation is something that we need to address with most well visits when they come in, and any sick visit that has to do with lungs and upper respiratory. I believe that's the end of our respiratory lecture, and if you should have any questions, please feel free to let me know. Thanks.